Addiction is often described as a loss of control, but a mechanistic understanding begins with habit formation. Not all habits are pathological. Normal habits are efficient, flexible, and can be suppressed when goals change. Addictive habits are different. They become overlearned, insensitive to consequences, and resistant to cognitive control. The central question is not simply why substance use begins, but why behavioral control shifts and fails to return to goal-directed regulation. The primary circuitry involved is the cortico-striato-thalamo-cortical system. Addiction is defined by a progressive transition from ventral to dorsal striatal dominance. Early in use, the ventral striatum encodes reward value, prediction, and motivational salience. Over time, control migrates toward the dorsal striatum, which governs stimulus-response habits. Once this shift occurs, behavior becomes cue-driven rather than goal-driven. The individual may no longer seek pleasure, yet environmental triggers continue to activate learned action programs. A central mechanism underlying this transition is corruption of dopamine prediction error signaling. Under normal conditions, dopamine neurons fire in response to unexpected rewards, allowing learning to occur. When a reward becomes predictable, dopamine responses diminish and learning stabilizes. In addiction, dopamine signaling becomes exaggerated and persistent. Learning continues even when outcomes become harmful. Environmental cues gain abnormal motivational power, producing a state often described as wanting without liking. This explains why craving can persist even after the pleasurable effects of a substance decline. Insight alone rarely stops addictive behavior because control has shifted away from declarative decision-making. The prefrontal cortex may recognize the harm and generate intentions to stop, but the dorsal striatum executes automated behavioral sequences. This reflects procedural dominance rather than moral weakness. The nervous system continues to run a learned program even in the presence of conscious resistance. Several secondary systems reinforce this pattern. Stress and threat circuitry involving corticotropin-releasing factor pathways, the amygdala, and the bed nucleus of the stria terminalis convert use from reward-seeking into relief-seeking. Interoceptive and autonomic systems amplify withdrawal sensations, allowing internal bodily states to trigger craving. Prefrontal control networks weaken over time, reducing inhibitory control, impairing delay discounting, and diminishing error monitoring. These processes do not initiate addiction but contribute to its persistence. The sustaining loop can be summarized clearly. Cue exposure activates dopaminergic drive. Dopamine facilitates habitual action. The behavior produces short-term relief or reinforcement. That relief strengthens the stimulus-response association, making future responses more automatic. Negative consequences fail to weaken the loop because learning is no longer guided by outcome sensitivity. A concise mechanistic formulation would be this: addiction is a disorder of maladaptive habit learning driven by corrupted dopamine prediction error, resulting in a shift of behavioral control from goal-directed prefrontal systems to compulsive dorsal striatal circuits, with stress and interoceptive amplification. This framework also helps differentiate addiction from obsessive-compulsive disorder. In OCD, behavior is driven by persistent error signals without reward learning. In addiction, behavior is driven by reward learning that no longer updates in response to negative outcomes. Understanding addiction through this network-level perspective reframes treatment targets. The goal is not simply suppressing craving, but restoring flexibility within learning systems, strengthening prefrontal control, and reducing the impact of cue-driven habit circuitry.